Hi, this is Duncan Ferguson. We're continuing in part 3 or module 3 of our glucocorticoid therapy and small animal practice discussion. And in this section, we're going to talk about what we call physiological replacement therapy. That'll be a low dose. We'll go to a really high dose, talk about shock therapy briefly, and then we'll talk about a mainstay of any practice use of glucocorticoids is anti-inflammatory therapy. So as we move into the actual clinical application of glucocorticoids, I'd like to sort of provide a few guidelines that you might want to think about as you start trying to apply them in clinical practice. And the first one is it's always good to make a diagnosis. And the reason for this is that steroids are very powerful drugs that may mask signs of disease. And therefore, as you use them, it'd be very important to lay out some very specific objectives. In other words, you're trying to keep that animal from scratching itself if it's got an allergy, or you're trying to raise the red blood cell count if you're treating an immune-mediated hemolytic anemia. And of course, each of these indications will lead you to a specific dosage range, a frequency, and a duration of therapy based upon the disease. And we'll talk more about that as we talk about each class of use of glucocorticoids. Above all, realize that you're never going to cure anything with glucocorticoids. There are no diseases that actually are cured by forever by a course of glucocorticoids. In that dosages are experiments. So giving a dose of any drug, but particularly glucocorticoids, is about doing a trial and error and making sure you have objectives to go on that you and the owner agree on, and that you can reevaluate those objectives to make sure that glucocorticoids by themselves are doing the job, and or you have the right dose, or you could decrease the dose, or maybe you need to increase the dose. Continuing our guidelines, the first one here may sound counterintuitive, and certainly in starting certain types of therapy, we don't want to use intermittent therapy, but realize that the administration of glucocorticoids have a cumulative effect on the animal that can be negative. So if we're trying to treat an animal, let's say, for an arthritic condition and a non-steroidal anti-inflammatory drug doesn't do the job, if we think we have to use glucocorticoids, let's use it just during the season or during the flea allergy season. Let's try to be reasonable about maintaining animals on long therapies. And of course, pre-evaluate that animal for the tendency for them having conditions that would be exacerbated by glucocorticoids, such as infectious disease, or pre-existing Cushing's syndrome, diabetes mellitus, for example. Glucocorticoids can, in certain species, in the dog, for example, could lead to problems with pregnancy in any animal that's prone to a seizure. And if you have conditions like congestive heart failure and renal disease, try to stay away from those glucocorticoids that have that higher tendency for mineralocorticoid activity. And you can look at that on the table that we talked about in Unit 2. A physician almost 50 years ago made the suggestion that a clinician should ask certain questions before using glucocorticoids. And the first one is, how serious is the underlying disorder? And this relates to how long you're going to have to treat, for example. So that's related. So number 2 is related to that. So this leads us to that question. And of course, as we said in the previous slide, do you have a patient that's predisposed to problems that would be exacerbated by glucocorticoids? It might lead you to, particularly today, 50 years later, when we have other immune suppressant drugs, we may want to avoid using glucocorticoids. And question number 1 often tells us about our last question here, which is, what's the anticipated steroid dose? We want to use an appropriate dose, and we'll talk about that as we go forward. he went on to say we need to look at what glucocorticoid preparations we want to use, and also see if we've minimized our use of glucocorticoids by either reducing the steroid dosage, particularly after chronic administration. If we absolutely found that point between where the animal responds and where it doesn't respond, and can we minimize side effects and things like ulceration, infectious disease suppression. And finally, and we'll talk about this a little bit towards the end of these units, is alternate day regimen possible for this condition and in this animal? An alternate day regimen is, the benefit of that in theory is to give time for the normal axis to recover on the day off of therapy, and if the disease can be managed that way, then that tends to result in fewer side effects overall. I like to classify the actual application of glucocorticoids in the clinic in different categories, and we will talk about in this unit the first three, and we'll also sort of allude to the fifth one. The fourth unit module will be covering immunosuppressive therapy. So each of these is meant to put you in a certain category of dosage and types of glucocorticoids you want to use. And what the dosages I'm going to give you are just guidelines. I'm going to focus on using prednisolone because it's something I've become used to using as an intermediate acting glucocorticoid. So the first class of usage of glucocorticoids is physiological replacement therapy. In situations where we've either taken the adrenal glands out or we've suppressed them dramatically with glucocorticoid, pharmacological glucocorticoid administration, or in Addison's disease. And so these are the three main indications. In the situation of replacing the physiological needs of an animal, we usually think about that an animal will produce about 1 milligram per kilogram of cortisol per day. And what does that tell us? That's actually something that seems to be consistent between most of the species we deal with, and so that translates to this recommendation here for replacing that glucocorticoid, either with hydrocortisone or cortisone, where cortisone is converted to hydrocortisone by the liver, or with prednisolone, which is, as we said, roughly 4 to 5 times more potent than hydrocortisone. Generally, we give it once a day, and that's actually to just a practical aspect. It's probably all the animal needs. But we have to recognize that this is just the resting amount that the animal needs. In other words, a non-stressed amount. If you start to anticipate, and the owners have to do this too, that the animal would become stressed, you may want to supplement that. So if moderate stress, several-fold to 5-fold, and severe stress, for instance, a surgery, it may be counterintuitive, but surgery will increase cortisol levels quite a bit for about a week. Anesthesia and surgery will do this. And so you have to sort of train the owners to anticipate how their animal reacts to these situations. They need to have extra glucocorticoid in the situation to be able to play Mother Nature, as ACTH would normally go to the adrenal gland and say, I need to make more cortisol, I need you to make more cortisol. That adrenal gland can't do it, and so it has to be anticipated by an owner and by you. In this slide, I'm sort of jumping to the other high end of the dosage range, of course, but I want to just simply put in one slide about intensive short-term and shock therapy. A full discussion of it would require a much longer discussion. The main thing is that there's some controversy over the beneficial effects in shock, but if they occur, they're probably through those membrane receptors that we discussed. And so plasma membrane glucocorticoid receptors, and there's probably a key window of time, probably less than 4 hours after an insult, For example, if an animal loses blood being hit by a car, or in the initiation of septic shock. Well, what's the controversy? Well, are you going to suppress the immune system? And I think you have to make that decision in each case individually. But certainly, you can manage an infection that occurs if the animal dies due to cardiovascular collapse, and you believe the animal could have benefited from glucocorticoids. That's something to think about. Generally speaking, short-term therapy, less than 2 days worth of glucocorticoids, is going to have very few negative effects, and I think probably the positive effects in that situation will outweigh the risk. Of course, you need to give fluids. Fluid therapy is our most important therapeutic approach with shock. Well, let's turn to a bread and butter use of glucocorticoids in small animal practice particularly, and that's the anti-inflammatory and anti-allergy therapeutic use. Examples of this would be allergic pruritic dermatoses, allergic pulmonary disease like asthma, or allergic gastroenteritis such as inflammatory bowel disease, so IBD or asthma. And generally speaking, and remember I'm using prednisolone because it's just to talk about a dosage, and it's useful to see these dosages in relative terms, and prednisolone at around 1 milligram per kilogram, usually divided until effect. And that's why you need to have a clinical objective to say, okay, I'm going to stop the animal from self-traumatizing, or I'm going to help the animal breathe better, and then I'm going to back off. And you can back off to a maintenance dose, that, usually in cases like this, that may be even every other day. In cats, we generally have a rule of thumb that you need more glucocorticoids, roughly twice as much, and we'll talk about some of the reasons for that. And there's a couple of, there's a resistance issue as well as the fact that they absorb glucocorticoids less well given orally. So what about cats and glucocorticoids? The next slide we'll talk about that. So we're going to end this module with a discussion of glucocorticoids in cats. In general, cats are believed to be more resistant to glucocorticoids, and that's manifest by having half the density of glucocorticoid receptors, at least in the skin and the liver, compared to dogs, and lower binding affinity, meaning you need higher concentrations to get the same effect. Cats also tend to respond better to prednisolone than prednisone, and so the evidence for this is severalfold and been developed over the last 10 years or so, that the absorption given orally of prednisone is only 21% compared to almost complete for prednisolone. Furthermore, we know prednisone, which is a prodrug, needs to be activated by the enzyme hepatic 11-beta hydroxysteroid dehydrogenase in the liver to prednisolone. And so, in addition, there can be a conversion back from prednisolone to prednisone. And a recent study has shown that the administration of prednisolone results in 4 times higher area under the curve, that is plasma concentrations for prednisolone, than what you'll find at the same dosage for prednisone. So there's obviously an absorption issue, and there's a conversion issue going on in the cats, making them more resistant to at least that particular type of glucocorticoid.